Hi, good afternoon. My name is Justin Frazier. I'm a director at Mazars Healthcare Consulting Group in New York City, and I'm with my colleague Devin Judge, who's a manager in the Healthcare Consulting Group, also in New York City. And today we are going to discuss whether a healthcare entity should consider being involved in the CMS direct contracting program. How are you doing today, Devin?
I'm doing well, Justin. Thanks so much for having me, and I'm excited today to talk about this subject.
So just as a first question, Devin, can you tell me about the direct contracting program? What exactly is it?
Sure. So if you're familiar with ACOs or the MSSP program, the direct contracting program, which I might also refer to as the DC program, is another exciting opportunity for healthcare providers to one, take a more active role in managing their patient care, and two, potentially to earn shared savings by entering into a risk-based contracting arrangement directly with CMS. Providers get to form these strategic partnerships by contracting with either providers or suppliers and vendors to perform as a collective entity, also known as a direct contracting entity, or a DCE. And the DCE is the performing entity that CMS measures for both managing the quality of care and the medical expenses of its participating providers' attributed beneficiaries. And the participating providers are kind of your PCPs typically, or your entity that carries the beneficiaries and all the claims that is measured in this program. The strategic partnerships between the participating providers and the preferred providers, which is the terminology used in the RFP, also allows the DCE the ability to earn more predictable capitated revenue streams and to offer innovative benefit enhancements like expanded home health services or chronic disease management rewards in order to incentivize its beneficiaries and better manage its population.
That sounds really interesting, Devin. What are some other kind of benefits of the direct contracting program?
In addition to the features that I just mentioned, the direct contracting program was designed by CMS with the goal of reducing administrative burdens for the providers in order to make them, in order to allow them to spend more time managing their patient care, and also offers the opportunity for participants to grow their Medicare fee-for-service beneficiary volume through different types of claim-based alignment.
Oh, thanks for that, Devin. What are the different types of direct contracting entities?
So based on the type of organization that you are or the type of population that you would be serving, there's three main types of DCs and one new one that recently came out or was announced this year. But the three main ones are the standard DCE, which is an organization that has has a lot more substantial experience serving traditional Medicare fee-for-service beneficiaries, including dually eligible beneficiaries, and who are aligned to the DCE through voluntary or claims-based alignment. And there's a new entrant DCE, which is an organization that typically hasn't served traditional Medicare fee-for-service populations in the past, but would like to start serving that population. And they will rely primarily on voluntary-based alignment, at least for the few first performing years of the DCE program. And then there's the high needs population DCE, which is an organization that has a lot of experience serving traditional Medicare fee-for-service beneficiaries with complex needs, including the dually eligible beneficiaries who are aligned to the DCE, again, through voluntary or claims-based alignment. And this model, again, is specifically for entities that have experience using a model of care designed specifically for beneficiaries with complex needs.
Thanks, Devin. So before deciding if a provider wants to apply or what type of direct contracting entity the provider wants to be, what should potential provider applicants consider?
So there's four key features that whether it's a value-based arrangement or any other kind of risk arrangement that you're entering, that you should consider, or that potential applicants should consider if they're interested in applying to the program. Those four features are attribution, finances, partnerships, and quality. So attribution is large component of most value-based risk arrangements. Your risk pool is what's carrying your expenses and your performance. So for attribution, you want to ensure that your DC has a large enough risk pool if you're interested in applying. You want to ensure that it's balanced and has enough members to reduce any potential volatility that there may be if there's any unpredictable hospitalizations or other high expenses that you may incur. The DC has a glide path timeline for DCs to build up to 5,000 beneficiaries for new entrant DCE types. And then there's a glide path of 1,400 beneficiary threshold over the course of the 5-year program. For finances, the DCs are not required to demonstrate the same amount of financial reserves as ACOs, and may propose a financial assurance plan instead, such as having funds in escrow or using a line of credit. And it offers a variety of options to propose an alternative financial mechanism for approval by CMS. For partnerships, the DCs are comprised of participating and preferred providers. Those participating and preferred providers are required to align Medicare fee-for-service beneficiaries to the DCE, while preferred providers are optional and don't align beneficiaries. But for this reason, the participating providers cannot be aligned to more than one DCE, nor simultaneously participate in another CMS shared savings program. So those are two important features to consider. And then the last one is quality. CMS's quality goals for the DC program are to provide achievable performance criteria that aim to reduce utilization and improve quality of care metrics. The DC direct contracting program quality measures and performance standards are designed to reduce the provider's reporting burdens. That way they can focus more on beneficiary outcomes and experience than on the process.
Wow, thanks, Devin. You said a lot, and you said some really interesting things. So, when's the next application period, and how if I'm a healthcare organization and I want to consider it, when do I apply?
Well, thanks, Justin. You've been a lovely host. So the next application period for the second cohort of the direct contracting program just opened on January 1st, 2021, and will close at the end of the first quarter in March. The applications will be reviewed over the spring, and CMS should release their approved applicants by late summer. Mazars has already helped clients with their direct contracting applications, from their selections, their narratives, and their submissions, which were approved by CMS last year. These applications tend to require a lot of collective decision-making and information gathering, so the process can take anywhere from a few weeks to a little over a month, depending on how much of your DC structure you have defined. So you definitely want to start the process early if you're interested in applying.
Wow, thanks for that, Devin. This is a really exciting opportunity for a provider and potentially a new revenue stream. So it's something to think about. You said a lot today. If any of our listeners have some questions and they want to reach out to you, what's the best way to contact you?
Absolutely. So if they can see this presentation, there's a link to my email and my LinkedIn in the presentation itself, and they can reach out to me through there if they have any questions or want to learn any additional details about the program.
Well, thanks a lot for your time today, Devin.
Thank you, Justin.